Dr. Makhni is an orthopedic surgeon in Detroit and team physician for the Detroit Lions and Detroit City FC. We talk about my favorite body region, the shoulder, specifically shoulder instability. Dr. Makhni breaks down the common mechanism of injury for shoulder dislocations and subluxations, the initial phases of rehab, who needs or doesn't need surgery, when he recommends using a brace, and much more. You guys will love this one.
The Prehab audio experience will teach you how to take control of your health through knowledge by optimizing performance, promoting longevity, and keeping your movement system in tune. Welcome to your host, the Prehab Guys.
As you guys know, we got Dr. Makhni here. We're going to talk about all things shoulder instability related. What we'll start off with is have Dr. Makhni introduce himself. We got a few questions that we wanted to go through. And if there's any other questions that you guys have off the top of your heads, feel free to drop it below and we'll do the best to answer your question throughout this IG Live. So Dr. Makhni, why don't you introduce yourself and tell people a little bit more about what you do?
Okay, thanks, Arash. Hopefully you guys can hear me well. My name is Arash Makhni. I'm a sports medicine orthopedic surgeon at the Henry Ford Health System in Detroit Metro. I actually grew up, raised in Florida, did all my schooling in Boston and my training in New York in orthopedic surgery. And then I did my fellowship in Chicago in shoulder and sports medicine. Right now, I'm one of the team physicians for the Detroit Lions and also our local pro soccer team, the DCFC.
Very cool. How long have you been there for?
So we are now coming on 3 years here, and I do confess I kind of ended up here kind of randomly through one of your mutual friends, Dr. Nima. He's a friend of mine. That's how I end up in Detroit out of the blue. And I came with my wife. We love it. We just had our first kid, so we're digging it.
How's the weather right now?
It's 70 or so. So you caught us on a good day. It's actually still bright out. So we're at the western tip of the Eastern time zone. So it stays light out much later. So we benefit there. So the summer's kicking in. We don't have much of a spring or a fall. So we go right from winter to summer. So it's kicking in. We're pretty happy.
Enjoying it. That's awesome. So let's break down the shoulder anatomically. Can you give an idea of what a normal shoulder looks like and where it gets its stability? That way we'll know what shoulder instability really is.
Yeah, so shoulder instability kind of encompasses a broad term with lots of different meanings. So the shoulder, the best way to describe the shoulder is it's a ball and socket. And we always like to describe it like a golf ball and a golf tee, where the golf tee is the socket and the golf ball, which is the head of the humerus. Between the shoulder and the hip lies in that bony arrangement. So if you think about the hip joint, the hip's also a ball and socket, but that socket's really deep. And so the hip does not have a lot of flexibility in the motion. So it's a very stable joint because it's surrounded by that socket. Whereas the golf ball and golf tee analogy, there's a lot of motion with the shoulder. And we use our shoulders for all kinds of different motion, for stretching and sports and all kinds of activities. And because of that, we don't have as much bony stability. So the socket, which is the glenoid, is relatively small compared to the socket of the hip. And it's a good thing and a bad thing. Because we have a lot of flexibility, because the bony surrounding is shallow, we're able to do a lot of different things with the motion of our shoulders, stretch in different directions, all the way back, behind our shoulders, raise our hands all the way overhead. But the problem that comes with it is that there is not a lot of bony stability. And so we really rely on a lot of soft tissue restraints, muscles, tendons, ligaments, and cartilage to really give us our shoulder stability.
Right. Yeah. And so let's break down the few different types of shoulder instability that you would see in the clinic.
Yeah, I think there's really two main types. And to really boil it down to a simple way, it's either instability that comes when the shoulder goes out the front of the shoulder, out of the socket, or when the humeral head goes out the back. By far, the most common way of shoulder instability is with that humeral head coming out the front. And it comes out the front and a little bit lower, and we call that an anteroinferior shoulder dislocation. That is by far the most common. Another way it comes out is posteriorly, and that's much less common. It can happen in really bad trauma or in people who have seizure disorders or who gets electrocuted. Those are the notorious types of injuries for posterior instability. But anterior instability is by far the most common.
Yeah, that's the only thing I've seen in the clinic is, for the most part, actually the only instability I've seen is anterior instability. And I've read upwards of like 90, 97% of shoulder dislocations are anteriorly. So for those that don't really know, if the shoulder's here, the ball is actually coming forward and down a little bit, right? That's where that anterior inferior instability or that anterior inferior subluxation or dislocation is really occurring.
And the big thing is, go ahead.
No, go for it.
And the big thing to remember is what is holding the shoulder in place. And that is the key to what gets injured. So simply put, there's a bumper around the bone of the socket, and that's called the labrum. And you often hear about labral tears in the shoulder. Some of those labral tears cause pain. Some are because the shoulder has dislocated and ripped that labrum. There's a capsule around the shoulder, which is basically like the wrap around the shoulder, and that gets stretched when the shoulder dislocates. And then you have a series of ligaments in the shoulder capsule, as well as the rotator cuff, which are the tendons around the shoulder that also help give stability, in addition to some other structures like the biceps tendon and so forth. But the main stabilizers are that labrum, the capsule, and the ligaments and tendons around the shoulder.
Yeah. And then what would you say in terms of the most common mechanism of someone dislocating or subluxing that you see in the clinic? So just to differentiate for the people out there, there's a traumatic way of getting it, and then there's also just this multi-directional instability that someone may have because they're just very lax generally. And these are two different types of dislocation. One means that someone is inherently at risk just because their ligaments are lax and they're loosey-goosey. And then the other is there's actually an injury that forced someone to sublux or dislocate. And so that's what I'm curious about is what is it that you see most commonly that creates this dislocation?
And, you brought up a good point using both words subluxation and dislocation. So a subluxation is a partial dislocation. That's probably the best way to think about it. And patients will say, my shoulder shifts, but it doesn't come all the way out. The patients who say my shoulder came all the way out usually have to go to the emergency room and get it put back in. We call that a reduction. And so, we take care of a good number of athletes and football players, especially when the fall comes around. And one of the most common ways that they dislocate their shoulder is through a traumatic mechanism. And the arm comes in a period of abduction and external rotation. And what happens, that pushes the shoulder out of the socket because of that vulnerable position. Whereas in posterior instability, it's internal rotation and adduction, and the shoulder goes backwards. So when the shoulders are like this, so that can happen if you're tackled. It can happen when you fall down the stairs, and it can be in anyone. We've taken care of shoulder dislocations in patients as old as 76, 77 years old. So that's the most common. The folks who have the multi-directional instability are folks, oftentimes teenagers, young adults who have loose joints in their fingers, elbows, their shoulders, of course, their hips. They complain of popping in different joints. And in those patients, the shoulder can come out in multiple different directions. It can come out the front, out the back. It can come inferiorly down below. And they have this feeling that their whole shoulder is loose no matter what direction it is.
Yeah, no, that's a good point. And that kind of goes into how we would approach when someone presents to us with shoulder instability. I guess they would probably come to you first, where they're like, hey, something happened to me, doc. What would be your rationale to make the next decision in terms of imaging, in terms of going in and operating? I guess what are the big things that come into your mind in terms of who's a good candidate for going through these images versus who can we just get to do some PT, and with strengthening and stabilizing, we can probably have a better prognosis?
Yeah, I think this is probably one of my favorite conditions to treat in sports medicine because it truly comes down to the patient and the individual patient, activity level, age, level of competition. So one broad way of thinking about it is, let's say you have someone with their first shoulder dislocation where they say, doc, my shoulder came out of the socket. I had to go to the emergency room and they had to put me to sleep and put it back in. The first thing I'm looking at is age. Patients who are over the age of 40, there's a 50% chance they tore their rotator cuff. Patients under the age of 40 have a higher chance of tearing the labrum. So for everybody, we get an x-ray. Now, if they were in our emergency room at the hospital, we have the access to it, but otherwise I'll get x-rays to make sure no bone was broken. Because in addition to tearing the ligaments or the tendons, you can actually break the bone on the socket or on the humeral side, and that's a bony injury. So I'll make sure there's no bone issues, because if there's a big bone issue, that may force me to act right away. Assuming there's no bone issue, if they're over the age of 40, I make sure I get some sort of imaging for the rotator cuff, an ultrasound or an MRI. And if they have a rotator cuff tear, we presume, and you can see from the imaging, that it was an acute injury, that meaning that it just happened with a dislocation. And that will force my hand into recommending that we fix that tendon while we have a chance to do it. For young adults, for athletes, it all comes down to their mechanism of injury and their level of sports. So for example, if it's a high school football player or a collegiate or professional football player, often we'll get an MRI to see what the extent of the damage is. There is a 70 to 100% chance if you dislocate first time and you're under the age of 35, you'll dislocate it again and again and again. And the more research we are producing, it all shows that the more dislocations you have, the more the cartilage gets damaged, because every time that shoulder comes out of socket, that cartilage gets hit over and over, and the capsule or the wrap around the shoulder, that gets more and more loose and more stretchy. So people who have dislocated a number of times, they may say the first time I dislocated was in a football injury, but I've dislocated 10 times since then, and now I'm just dislocating in my sleep. That means that the cartilage has worn down, the bone has worn down, and the capsule has now gotten very capacious. And so it keeps dislocating over and over and over again. And it's kind of striking. If you go and surgically fix a shoulder arthroscopically that has had one dislocation versus 2, 4, 5 dislocations, you'll see in the patients who had multiple dislocations, you'll see a total degradation of the cartilage that's affected, the soft tissue, the labrum is poor quality, it's healed under the socket, it's hard to come back. So if you can fix someone who's dislocated the first time, and not everyone needs surgery, but in the situations that do, you can see the tissues are much more fresh, much more viable. So what it comes down to is, for my younger patients, my athletes, if they're an athlete, I will typically get an MRI right away. I want to see what's injured, and it helps them plan. So this season, I had 2 high school athletes that had their first time dislocation sometime around Thanksgiving. One was a senior, one was a junior. The senior told me, I'm not playing football after high school. I just want to make it to the season. So we had a very different approach to that player. We got them back with a brace, and we can talk about all that, and we got them to finish their season. The junior is trying to go to college, and he's a linebacker. So right after the season was over, and it was towards the end of the season, we fixed his shoulder right away so that he can recover in time for summer camp and for recruiting and get back for his senior year. So what it comes down to is not only what sport they play, but also what year they are and what their aspirations are.
That's such a good point. I mean, you broke it down very well, and that was kind of going into what I was going to bring into next is the people that are younger. It seems like you have to play the stats. If they're at this high of a risk of redislocating, I mean, let's make sure that they're taken care of and play these odds in our favor. Where let's make sure that's not happening again, which is crazy. You said 75 to 100% of people under the age of, was it 30?
35, yeah.
35. Wow. Yeah, that's crazy. And I was going to say too, like I've heard in regards to people that don't recover within 1 to 5 weeks have a worse prognosis too. Is that something that you've read?
Well, I think that, once they have the dislocation, if they're in the season, if they're in the middle of their season, what we're going to try to do is get them rehabbed. And that consists of getting their range of motion back, their strength back, and making sure they don't have any apprehension on physical examination. That's the biggest thing. And if we can get them there, then we feel comfortable letting them go back to play. And there's a lot of controversy. There was a couple papers recently that said maybe there's a higher return to play rate and a higher rate of not dislocating in people that don't get surgery right away that are young football players. And so we go back and forth a lot. Some people say, well, in the knee, if you tear your ACL, you automatically get surgery because the knee is unstable and the cartilage can keep getting injured. So why don't we do that with the shoulder or when a kneecap dislocates? So there is a lot of controversy. And what I do is I basically just sit the patient down and tell them the research. There's a high chance you're going to dislocate again because you're young. If you keep playing football, there's a high chance you're going to dislocate again because you're a contact sport. If you keep dislocating, we know that the cartilage and your likelihood of having a good outcome goes lower the more you dislocate. But surgery is not benign. You can have a complication, you can have an infection, you could have persistent pain, you can have all kinds of things happen. And so surgery is not a walk in the park. And it also depends on who's doing your surgery. If you have a surgeon who does a lot of these and has training in treating shoulder instability, that's different than someone who just does 1 or 2 a year, because they can actually make you worse. So all those factors come in. Our job is to say, this is the research, and let's ultimately make a decision. And if they're a teenager, then them and their parents or their guardian, and they make that final decision.
Yeah, I think you brought an interesting point up with the apprehension component of it, because in the clinic, I'll see, for example, you refer to physical therapy. Hey, this patient has shoulder instability, eval and treat. Let's strengthen them up. But what I see is I kind of have to take it back a step and approach it similarly to what I do a post-operation, where someone is so apprehensive that they don't even want to move. And a lot of what I do is instilling confidence with getting them to start moving again, just because they're so fearful of having this shoulder dislocate again. But it's really starting them off from square one. And I think a big thing going into rehab is what I like to focus on is close kinetic chain exercises, where I start getting their arms. What I mean by close kinetic chain, for those that don't know, is when I put my arm up against a firm surface and my system is closed. Like if I put my arm up against a wall or a floor, I have some feedback, and that gives me a good ability to create a co-contraction with the muscles surrounding my shoulder. Because really the key here is trying to get those muscles activated again to create a little more sense of stability. Because as we know, there's more instability when a little bit of that labrum is torn, because the congruency of the joint is not fully there. And then,
Absolutely.
What I wanted to get into next was when you would prescribe a brace, or when you would get people to use a brace versus when you would just get people to start moving on their own. I know that like everything we're talking about, some of it is up for debate and there's no perfect answer, but what goes on in your mind when you're thinking about giving someone a brace or not?
Yeah, so the brace, in my opinion, and others may have different opinions, but in my opinion, the brace is a tool to help the player get back to playing. So let's say it's a football player, for example, and they dislocate their shoulder. We get them back and they come see me back in the office. Their motion's great. They feel strong. They feel stable. They say, doctor, I need a brace. It depends on their position. If they're a position player that needs a lot of range of motion of the shoulder, well, the brace is going to limit you, right? So it's hard to use that brace if you're doing basketball or anything of those sports or an overhead sport. If they're a linebacker or they're keeping their arms kind of at chest level, then a brace is really good because it keeps them nice and loaded. And actually, there's a question that came up right now about, there's a baseball player and he said he has a glove side dislocation. That's a really good point to bring up. So not only do we look at the sport and the age range, we look at the position and the arm. So on my YouTube channel, I have a video of a baseball player with a glove side dislocation who has dislocated multiple times. If it's your glove side and you're an outfielder, for example, you're going to be diving on that shoulder nonstop with your arms outstretched. So you have a much higher chance of dislocating again than if it was your throwing shoulder. So all of that goes into decision making. And to answer his question, it's the same exercises to get shoulder stability as you would for a dislocation from a football injury. Is the goal is to have a stable shoulder with full range of motion and full strength. And if you have that apprehension, it means the shoulder is still damaged. And the brace we use after that initial recovery period, after a few weeks, and it varies for everybody, where the patient works with a physical therapist, they get all their motion, stability, and strength back, and they want something to keep them a little bit protected when they go back to sports. So that's what a laboring athlete that wants to get back to work, or a laborer for that example.
Yeah, I mean, it sounds similar to even when people tear their ACL. I know they get it reconstructed, they get back to return to sports. Some people, just for that confidence, still like that added passive stability with use of a brace, which
exactly
seems kind of like the same type of decision making here. Okay, let's go into, or I guess let's go into like the conservative approach. Let's say someone seems like they have a good prognosis without operating. So basically operative management, you go to PT. It seems like we'll first focus on range of motion, making sure they feel comfortable moving, like we talked about. After dislocating, people are very apprehensive to move, specifically into this externally rotated or arm out type position, especially in this 90-90 position as well. So I think that first thing we try to get people to do is get them comfortable with moving, whether it's just pendulums or moving into this forward flexion, which is when you bring your arm out in front of you. That's typically a little bit more comfortable than bringing their arm out to the side. And then we want to start activating. So my first thing to do is really getting them to start loading isometrically. I'll get the arm up against the wall, doing external rotation, internal rotation, flexion, extension, anything I can do to get that shoulder to start working. Not just the shoulder, thinking the glenohumeral joint, but also the scapula muscles. That's the muscles in the shoulder blades that is really the core of the shoulder, because the shoulder sits on the scapula. So we want to make sure the scapula is nice and stable. And then from there, we work into some closed chain exercises. I get into open chain eventually. I just don't like the shear force that open chain exercises create. So I like to stick with closed chain as much as I can for that co-contraction. Also, it helps with that proprioception, because you mentioned we have a little bit of a tearing of the ligaments or the capsule of the glenohumeral joint, which gives our shoulder a sense of proprioception, which is the body's ability to detect where it is in space. And so we want to gain that back. And I think that's why closed kinetic chain exercises are so great. And then we get into open chain exercises eventually. But let's say we go through that whole process and we don't get the individual back to where they want to be. And then they go back to you and they're like, all right, PT didn't work. Where would you take this situation?
Yeah. So I think you highlighted very well why I rely so heavily on a physical therapist, because there is a chain of events that have to happen to get the athlete back in action. And after the initial injury, there's a lot of swelling of the shoulders, a lot of fluid, and the shoulder's very inflamed. And often folks don't even want to move that shoulder. And I will tell you, if you don't get moving right away, you'll have the opposite problem where the shoulder will get very stiff. And so we start therapy literally right away, get the shoulder moving, and have our therapists go through that progression. When we see them back, there's usually, and they're still symptomatic, there's usually one of three things that are happening. One, it could be pain, and they don't have any issue with motion or stability, it's just that it hurts. And that could be if there was a labral tear or a fracture in the socket, and it just causes shoulder pain. The next thing that could be wrong is that the shoulder is now stiff. We see this with a lot of our folks who are older, middle-aged, who are not as active or don't go to physical therapy, and all of a sudden, all that inflammation has now led to scar tissue, and now the shoulder is stiff, and the shoulder has the opposite problem, and then it hurts everywhere you move it. So that's the second way this could be a problem. And the third way is if they come back and say, Doc, I did my therapy, I've got full motion, I got full strength, but it still feels loose, or it came out again. Then I move them into a camp where I say, look, now you have recurrent instability, and it's different. I recommend you get it fixed. Whereas before I'll say, okay, you can go A or B. Now I will say, you've dislocated twice, or you've dislocated and you're still apprehensive. That means you're not safe to go back to play, certainly not a contact or collision sport. My recommendation is that you get this fixed.
And when you say get this fixed, can you explain to people what it is that you would do briefly in terms of what you do in the operating room? I think that's kind of cool for people to hear.
Yeah, so, when we treat shoulder instability, it comes down to a few factors. And one of the biggest factors is, what is the status of the bone? As the shoulder dislocates over and over and over, it will wear down the bone on that socket until you're missing part of that golf tee. So the example would be, if you have a golf tee and the golf ball sits squarely on it, if you cut off half of that golf tee, the ball is going to keep falling over. So no matter what you do for a soft tissue approach, if the bone is gone, if the bone is missing, then you're in trouble. So the algorithm we think about comes down to, what is the bone? And we often focus on the bone in the socket or the glenoid, but the humeral bone does matter. But if you think about the bone in the socket, if the bone is there and it's just a soft tissue issue with a labrum or the capsule stretched, then my preference, and a lot of our preference, is to fix it with an arthroscope. So minimally invasive, 3 or 4 poke holes, small little tiny suture anchors in the glenoid, all arthroscopic, very safe procedure, but it has to be done well. If it's not done well, it's a very high chance shoulder's going to dislocate again. On the flip side, let's say there's 30%, 40% of the bone missing on the glenoid socket and it's worn away with time, we do what's called a bone transfer. And there's a few different types, but the main type is the Latarjet, where we take a piece of the coracoid, we cut it, and we move it onto the glenoid. And if you look up a Latarjet surgery, a Latarjet procedure, it's Latarjet, you'll see lots of schematics on how that happens. The Latarjet procedure is a very, very reproducible and highly successful surgery. The downside of the Latarjet is that you're now making an incision, so it's an open shoulder surgery. You've got to go through the rotator cuff, which is subscapularis, which in big muscular guys is very difficult to do, and there's higher chance of nerve injury. You're dealing with a lot of different nerves in the area, so you have a much higher chance of having a nerve injury, even though the chance is still small, but if it happens, it can be devastating. So the Latarjet, and then the Latarjet procedure, you have to use screws to fix the bone piece in the shoulder, and the bone piece can dissolve, the screws can migrate, the screws can break, all kinds of different things can happen. So it's not a benign procedure, but it is a very reliable procedure with less than 5% chance you have a recurrent instability. So the two extremes, the no bone missing extreme, the lots of bone missing extreme, the gray zone comes when you're at about 10 to 15% bone loss. And then we have ways to measure it, and it comes down to what kind of athlete are you? Are you a low demand athlete? Are you a recreational athlete? Are you not an athlete? You just want to get by doing everyday things? Then I may try to get by with an arthroscopic procedure. But if you're a contact athlete, collision athlete, hockey player, football player, or a soccer goalie, for example, if you have a little bit of bone loss, I may err towards doing a bony procedure like the Latarjet to give you the best chance to have a stable shoulder. So that's kind of what goes into the algorithm from kind of a 1,000-foot view.
Interesting. And then what about those elder populations? Because it seems to be that after the age of maybe 40, 50, not that you're old if you're over 40, 50, but it seems to be that there's also some other potential tissues that may be torn, like you were mentioning before, like the rotator cuff tear. And is that more common to do a rotator cuff repair simultaneous with one of these procedures with the elder population?
Typically what happens is, and there's exceptions to every rule, but let's say someone who's 50, 60, 65, 70 dislocates their shoulder, typically the main structure that's injured is the rotator cuff, and I try to fix it as soon as possible. I tell patients, look, it's like a rubber band. It just snapped, it pulled back. The longer you sit and wait, the ends of that rubber band are going to get frayed and non-viable, and the muscle's going to get scarred and atrophied. So we try to fix them within a few weeks, certainly within 6 weeks. I typically don't fix the labrum. Now, there's exceptions to every rule. Just 2 weeks ago, I had a 59-year-old construction worker who fell off a roof and dislocated his shoulder. Active guy, he looks like he's 40, very active guy. He ripped off a very large portion of the labrum, and he tore his entire rotator cuff with the supraspinatus off. And then he dislocated a second time 2 days later. So we fix his rotator cuff, and I actually fix his labrum at the same time, and I don't do that often, but he was a special case. There's another group of people, folks who are already stiff and then they dislocate their shoulder. Those folks often actually break the socket, and we call it a bony injury. And we can actually go in there and either sew the bone pieces back together or put a couple of screws in there to get it back. So the older patients or the patients over 40, a lot more higher chance of having a rotator cuff injury, and they can often have a bony injury, especially if they're already stiff to begin with, because then the capsule doesn't stretch and the bone is just forced to break off, and that's how it goes forward.
That's the bony Bankart that you're referring to?
Yeah. Try to fix those like any fracture, as soon as possible. But I'll tell you, we've fixed some that have been months out, and they do great, because I think part of it is that you fix the bone back, but by doing a shoulder surgery, an open shoulder surgery, there's so much scarring that happens that it actually forms a protective scarring that keeps the shoulder nice and stable.
Interesting. Yeah, that's kind of cool stuff. And I know that it seems like the literature in general with shoulder instability has been moving pretty quickly, because maybe 10, 15 years ago, I remember even before PT school, it seemed to be that people said, hey, wait 3 dislocations before getting surgery. And then now we have more specific guidelines, it seems like, even though there's not, like you're saying, one specific way, but you tell the patient, hey, this is where the literature is at currently. This is what I would recommend. And then based on that, let's collaborate and make the best decision for you.
Yeah, and as with lots of things in medicine, that pendulum moves. It's been moving to a point where we fix things quicker, certainly get imaging quicker. But some recent studies have shown that sometimes non-operative treatment is better than we think it is. And I think that if you have someone with a first-time dislocation, I don't think it's unreasonable to let them try to go back to sports without having surgery. But it changes if you're a collegiate athlete or a high-end elite athlete or certainly a professional athlete. If you're a professional athlete, you dislocate your shoulder, you can better believe you're almost always going to get surgery right away to fix that injury. And we see that all the time with professional athletes with their first time dislocation, they get surgery right away.
Yeah. Cool. That's a very good, basically understanding, I think, for the average person about shoulder instability. What I want to get into next is these questions. There's a few questions that we had previously when we asked you guys on the Instagram story. We'll go through a few of those. If there's anything else specific, feel free to drop it here. So the first one, let's say, why are we prone to an anterior subluxation? You kind of hit on this, but let's summarize that again.
Yeah, I think the vulnerable position is, again, this abduction, external rotation, forward elevation position. And we often find ourselves like that position if we're falling and we're bracing our fall, or if we're getting tackled or the arm gets pulled. The posterior dislocation is a little bit more of a nuanced position that certain populations, like those with seizure disorders or those who get electrocuted, have a little higher chance of the shoulder going backwards, but it's just not as common of an injury pattern.
I think anatomically, the way the scapula is set up at a 30-degree angle as well makes it so that it's a little bit more likely potentially for the anterior capsule to be stretched. And then I know in the clinic, I see a lot of people have a very stiff posterior capsule / cuff, and that can put a little additional stress on the anterior glenohumeral ligaments or the anterior shoulder. All right. Let's see. Actually, let's go into, let's say you did operate. I wanted to get into like your post-op protocol, just basically running through kind of like a 10,000 feet view of how you progress people from post-op day one all the way to return to sport.
So I break it up into a few phases. So phase one is that first 6 weeks. And my protocols are on my website if you Google my name, but they're pretty similar to a lot of folks' protocols. And it's similar for both the Latarjet and the arthroscopic. So the way I tell patients is, look, the first 6 weeks, you're going to take it easy, a sling for most of that time, some passive stretching just to get your motion better. Week 6 to week 12, we're really getting the slings gone. And we want to get you moving your shoulder more for functional activities, a lightweight, 10, 15 pounds, working your way into that and being able to use your shoulder so that when I see you at the 3-month mark, your shoulder is relatively functional, just not doing anything high energy. You start your weight training and you're strengthening at 3 months post-op, and then your return to sport is in that 5 to 6 month range. If you're a contact or collision sport, closer to 6 months. If you're a recreation athlete or a low demand athlete or a non-contact sport, closer to 5 months. So phase 1, 6 weeks, passive motion, shoulder stabilization, getting those kinetics back. Phase 2, 6 to 12 weeks after surgery, more active motion, starting to do some light strengthening, small muscle stabilization. Phase 3, 3 months onward, your strength training, and then back to sports 5 or 6 months after surgery.
Curious, do you ever recommend blood flow restriction training for any of your post-op protocols?
We are now incorporating BFR into our post-op protocols. We're especially doing it for the lower extremity where you can put the tourniquet above the knee, especially for our ACL patients, our patellar dislocation patients. We are doing some studies now, actually. We're getting ready to do some studies on BFR for upper extremity, so for rotator cuff or instability. I have a couple guys that we've done Latarjets on who are college football players, and they're great candidates to try out the BFR, and they seem to like it. So we're still learning, especially for upper extremity, but I definitely have seen some very good anecdotal evidence so far that it could help.
Yeah, it seems like most of it is on the lower extremity. And even with the upper extremity, from what I've been reading, it seems to be that the lower extremity cuffs actually create a systemic effect, which therefore can help with the upper extremity. However, that's cool that you guys are prescribing that. Okay, let's go back to these questions. We kind of hit on a lot of these. Oh, this guy, can you sleep on your side that has recently had a shoulder dislocation?
Sleeping on the shoulder, I kind of prescribe to the if it doesn't hurt, it's okay. Now, obviously, if you sleep on your shoulder side, you had a dislocation on, you put your arm in a position out here, whether you're sleeping on that side or not, you're at a risk for dislocating it. Certainly after surgery, you will. If you had a shoulder surgery, most people feel more comfortable sleeping in a lazy boy or sitting upright for a few weeks, sometimes longer, depending on the type of surgery after you have your procedure. But in general, I think if it's comfortable and it's safe, I don't personally have any objection to it, because when you're sleeping, you probably don't know what's going on half the time anyway.
Yeah, that's very true. We got a few of these questions in terms of best exercises for shoulder instability. I'll start with this, and if you wanted to add anything. So basically, the way I think of it is there's static stabilizers and then dynamic stabilizers. These static stabilizers are structures that we can't actively contract, like the ligaments, the labrum, which creates stability, the bones. These are static. The dynamic structures are the muscles that we can actively contract. And so we can't, like in PT, from our rehab perspective, we can't change the static structures, but we can improve the strength and stability of the dynamic structures, being the scapula stabilizers and then the glenohumeral joint stabilizers. So I think that a lot of what we do after we get mobility back, because that's number one, we want to make sure they feel not so apprehensive and comfortable to move, then do some isometrics. But really a lot of scapula stabilizing exercises like serratus anterior, lower trap, mid trap, rhomboids. That's always low hanging fruits, because the individual doesn't feel as fearful activating the scapula muscles. And then we'll go into some rotator cuff strengthening. And I think that subscap is very important. It's the strongest rotator cuff muscle, but the post cuff is just as equally as important. We got to strengthen the teres minor, the infraspinatus, supraspinatus, all of these muscles that surround the shoulder, even the deltoids as well. So there's not a specific exercise that would be ideal. It's more just making sure that you're progressively overloading so that you can eventually get back to what you want to get back to doing.
Yeah, I couldn't have said it better myself. I think the therapists have a far better view and handle on the intricacies of the rehab protocol. So I defer to our therapists all the time on this. So I think you couldn't have said any better.
Perfect. Here's a question. How did it's kind of a weird question, but how to differentiate between labrum tear and trigger points around the shoulder?
Yeah, I think the trigger points from the shoulder, and I confess I don't have a great understanding of trigger points, but the way I think about the trigger point is that there are spots of the shoulder that cause pain. The labral tear is a detachment of the bumper around the shoulder, and the question just that says, with a first-time traumatic anterior dislocation, is a Bankart lesion expected as well? And I think that goes hand in hand with what we're talking about now, and I say that if you're a young, active patient that does not have any fracture at the time of the dislocation, then almost certainly the labrum at the Bankart, the anterior inferior labrum, where the shoulder comes down, almost certainly the labrum detaches, and with it comes the capsule. And because of that detachment, that capsule and labrum detachment, you've now made the shrink wrap around the shoulder much more loose, and that's why you keep dislocating over and over again. And the more you dislocate, you stretch the capsule out even more, and then you start to wear that bone away, and that's why that golf tee gets short, like gets more and more cut off, and so the golf ball just starts coming off more easily.
Yeah, that's perfectly said. Yeah, that makes sense. Let's see if there's any other questions here. I saw one from earlier. This guy said, Richard N.A. Corda 8 said, fourth anterior dislocation, what is damaged in my shoulder? We kind of hit, I mean, you went through a lot of that already. I think that it's very case by case dependent, but it seems like you go through the x-ray first to rule out any bony abnormality. Yeah. If he's younger, then you want to, if they're older, you go through MRI also, because you're worried about soft tissue structure damage, right?
And for someone like that user who's had 4 dislocations, regardless of age, but more typically if they're a young adult or an athlete, if they come to see me after 4 dislocations, they are definitely going to get an MRI. The MRI can oftentimes tell us what the bone looks like. If the bone looks pristine on the MRI, I won't get a CAT scan. But if it looks like there's some bone missing, I'm going to order a CAT scan to get a better look at the bone. especially for any athlete with 4 dislocations.
Hmm. How often, I would say, or how often would you say that you do see bony damage or like these bony Bankart lesions out of the amount of dislocations that you see, like
If
percentage
it's
wise?
so I'd say the true bony Bankarts are probably maybe 10%,
Mhm.
10 to 15%. And it's kind of funny. At our National Academy, one of the international experts on shoulder instability from Japan put it very nicely. And I think I may have brought this up. If you have someone with a stiff shoulder and they dislocate from a trauma, they're going to break that bone. And so my adults over the age of 40, I've taken care of a number of them that have broken off half their glenoid, big guys or older patients or non-active men or women, because the shoulder is stiff and they just fall and it breaks. So they're the group that we fix right away. The other group is the folks who keep dislocating over and over again. They almost always have some degree of bony erosion.
Yeah, perfectly well put. And this is what the explanation I like to give my patients is that everything is a balance between mobility and stability. And the shoulder joint inherently has a lot of mobility, like you're saying. It's like a golf ball on a tee, where there's a really big ball and a small tee. And therefore, most people have a lot of mobility and not enough stability. I know that you gave an anomaly example right before this, but generally, if you lose a little bit of that stability, whether that's from overuse or whether that's just genetics, where congenitally you have lax ligaments, or if there was trauma to that shoulder, now you're at a significant increased chance of creating another instability potentially,
Absolutely.
depending on how severe the damage was. But I
And
think
that's why you hear if someone who's dislocated 10 times, 12 times, they say they dislocate in their sleep, or they reach something on a shelf and dislocated, or they're brushing their teeth, then you know the soft tissue is or bone is already compromised enough that clearly they need to get that restored, and it's a mechanical issue that needs to be
yeah,
fixed.
yeah. Someone just came in with a question: best shoulder stability workout. Funny that you asked, because I think we're going to turn this Instagram Live into a podcast, into an article, which will bring in an example or a playlist of exercises for shoulder stability. So stay tuned for that. All right. We like to end with 2 questions, Dr. Makhni. So I'm going to have you answer. I'll start with the first one. What does prehab mean to you?
So
Prehabilitation.
for me, prehab means getting the body ready to undergo whatever the next treatment is. Commonly, at least most commonly for me, it's a setting of a young athlete with an injury and they want to have surgery, but they're just not ready. So the typical example is an ACL tear. Hey doc, my knee blew up. I had an injury in the field and now I just can't move it and it hurts so much. And the exam imaging all says ACL tear. But if you do surgery on that person with the knee or shoulder acutely inflamed with all that swelling, that shoulder or knee is not going to do well and it will not get loose after surgery and the muscles will be broken down. So prehab to me is getting ready to undergo surgery so you can go undergo the proper rehabilitation afterwards. And that means restoration of motion and restoration of strength.
It's tough because insurance is so limited with the amount of prehabilitation or prehabilitative visits that they get with their therapist. And so it's tough, but it is very important, as the literature demonstrates. Okay. The second question: what is one piece of advice you would recommend for our audience in general? It can be anything.
Yeah, I think that the internet has allowed everybody, patients, docs, therapists, the opportunity to learn so much more than they would have 20 years ago.
Mhm.
Obviously, you have to take it with a grain of salt, especially on some message boards and dealing with all kinds of examples that are extreme. But now patients have the ability to learn about their condition and really take matters to their own hands. And so every risk of every treatment is out there, is public, and all the research is out there summarized. So I think patients now more than ever can empower themselves, and they should empower themselves, but also just try to understand what the doctor's saying and try to assimilate both their knowledge and the doctor recommendation. And it really, at this point in age, it is a patient's decision. Gone are the days when the doctor said, you need to do X, Y, and Z, unless it's an extreme example. Right now, it is shared decision-making, especially for all elective treatments. So the onus and the expectation is that the patient makes that decision with guidance from the doctor. So now's the time to be read up and to take your own health into your own in your own hands.
Yeah, empower yourself. Absolutely. I was reading a stat the other day, 60 to 83% of individuals in North America look up information before they see their any physician, which is crazy. I believe it. I mean, I have people all the time coming to the clinic telling me this is what they have when I haven't even done my examination yet. Okay.
Absolutely.
All right. Cool. Well, thank you so much for coming in and talking about all things shoulder instability related. I learned a lot. I'm sure that there was a good amount of people here that got a good amount of information from this. And like I said, we'll eventually turn this into an article and put it out for you guys to see an example of shoulder instability protocol that Dr. Makhni recommends. Thanks again, Dr. Makhni, for coming on.
Thanks so much, Arash. You guys are doing a great job. This is great.
Thanks. Appreciate it. Take care.
Take care.
Thanks for listening to this podcast with Dr. Makhni and I. Don't forget to rate, review, and subscribe to this podcast. This helps us tremendously and really allows us to get our message out there. If you or someone that you know is experiencing any type of shoulder discomfort, we actually just came out with our first program. This is a shoulder prehab program that's actually on our app that we recently dropped. So if you're not sure and want to check out more about this, please check out the show notes and it'll have some more information. Thanks.